connected to a ventilator.
And that, so after putting in the endotracheal tube, that would then be connected to a mechanical ventilator that would be getting the oxygen to the patient.
Correct. Not just giving oxygen to the patient, but giving breaths, giving artificial breaths and helping them breathe.
And then what is your training in regard to your use of propofol at all of UCLA?
Basically, when you're using a drug like propofol, which is a very potent anesthetic, it's really important to be aware of the side effects and the potential risks that are associated with it, and to know how to deal with those. I think one of the first rules we use as intensivists is to be well prepared for any type of a complication, but when a problem does arise, and an emergency situation does arise, is to remain calm and be methodical about management. So preparation is key, and one of the things in preparation is to really be aware. What are the risks associated with that? Now, we deal with a kind of a unique patient population because they tend to come to the ICU because they have some issue, some major problem, life-threatening problem that leads them to the ICU. So we're even more cautious. I can tell you, I don't use propofol as an induction agent in all my patients that I place on a ventilator. And the reason for that is some of these patients are unstable. As we're monitoring them continuously with blood pressure, heart rate, if I have a patient who is already sick, who has an infection, for example, who has hypovolemia, low circulating blood volume, and I see that their blood pressure is tenuous, meaning it's unstable, I actually don't use propofol as an induction agent. I tend to use another agent that tends to have a lesser effect on blood pressure, because propofol can have, particularly when it's used as a bolus, can have a pretty profound effect on blood pressure, particularly if you're dealing with other elements such as underlying volume status, the patient that is, has low circulating blood volume or who's infected. So that is very, very important to recognize.
And when it's being used as a deep sedation, does that require ACLS certification or training?
Absolutely. When we're actually, since we're a training program, even if we have residents who are training in internal medicine, we have to supervise them doing it. Even our fellows who I supervise, who are getting subspecialty training in the field of critical care and pulmonary disease, we still have to supervise them placing endotracheal tubes in the ICU, certainly after they've met criteria for having done enough of that procedure and have met criteria for deep sedation. There are tests that people have to take, then they're actually able to use it to induce patients. But we're very careful using it, and it's really restricted to either us as the intensive care specialist, or if we're not around, anesthesiologists are always there overnight in the hospital. The residents actually have to call anesthesia for doing that procedure.
And would someone then administering it also have, I guess as part of ACLS training, have airway management skills and training?
Absolutely. Airway management is really fundamental. Well, for the purpose that we're talking about here is that we're often using it is to induce anesthesia, to put a breathing tube in. You wouldn't be giving it if you didn't know how to actually put an artificial tube in. So you know how to use a laryngoscope, which is a device that you use to actually lift the tongue and look at the back of the throat and be able to see the vocal cords in the airway and place the tube in. So that is correct. But even in other circumstances that the drug is used, it is always necessary to have somebody that is comfortable and confident in maintenance of an airway and should be able to respond to the physiological consequences that may occur with the use of this drug and be able to reverse it.
How about the need to be able to recognize impairment or recognize where the patient is on the continuum of sedation?
Right. The continuum of sedation, I think, is an area that's big for us as well as anesthesia. And basically, there's a really fine line between patients that go from really what we call moderate sedation, where they are still responsive to verbal stimuli. When you're calling them, they're sleepy, they're in a dreamlike state, but they're able to verbalize, respond to verbal stimuli, to going into actually 2 steps further, meaning to deep sedation and then beyond to general anesthesia. There's a fine line, and that is referred to as the continuum with sedation. So in some patients, particularly that are predisposed because of underlying illnesses and issues, it sometimes is very hard to predict when one goes from being in moderate sedation and then falling into really a state of what we call general anesthesia, where they're not even responsive to painful stimulation. So that can often happen. And we in the intensive care unit are very, very, very serious about this. There are sedation levels of sedation that nurses have to follow when we actually even leave our patients on a drip on propofol, to make sure that there is not an accumulation of the drug, so that you're not giving too much of it. So it's important for there to be this titration or a lowering of the drug as necessary, depending on the level of sedation that one achieves, one is desiring to achieve. And normally, we always want to have the least amount of sedation to be able to do what it is that we're doing.
Now, in your practice in the critical care unit, when propofol is utilized, who is present as far as medical professionals?
When propofol is utilized for induction,
yes,
that's because that's an important question versus maintenance. For induction, there has to be either an intensivist, an ICU specialist such as myself, or an anesthesiologist present. Those are very, very, very strict rules. Now, there are hospitals that may not have an anesthesiologist overnight, for example, and I do understand that this is still in the community where people still have emergency room specialists or ER doctors, but they too are very comfortable and confident in the management of the airway and complications that can arise from the use of a deep sedative such as propofol.
All right. And present then would be, you have a nurse on hand?
Right. A nurse is always present, and actually when we are using this drug in the intensive care unit to anesthetize a patient, to prepare them for putting placement of a breathing tube, we actually have the nurse pushing the drug, monitoring the vital signs, which are the heart rate, the blood pressure, the respiratory rate, the oxygen saturation, continuously at that time. Absolutely. We're never alone.
Okay. And you would also have probably a respiratory therapist?
A respiratory therapist is always in hand when the decision is made to put in a breathing tube. The only caveat being sometimes things can occur in an emergency in the intensive care unit, and you do what you do and you just call for help or call what we call a code blue. And that may be the only exception where some of the people, like a respiratory care specialist, may not have time to make it there. But with that exception in mind, they're always present.
And you just touched on it briefly, I believe, but in your practice, again, in the critical care unit, the required monitoring equipment is what?
The required monitoring equipment is a continuous EKG or electrocardiogram monitor, where we're not only seeing the heart rate, but we're actually seeing the waveform or the pattern of the heartbeat to make sure that not only are we monitoring the actual rate, whether it's too high or too low, but to look for irregularities or arrhythmias or abnormalities in what we call the QRS complex, the heart rhythm. So that's being monitored continuously. We're monitoring blood pressure continuously, and most would agree. Depending on the severity of the illness, we're monitoring every 2 to 3 minutes. We're monitoring the pulse oximeter, which is the oxygen saturation. that is measured via a probe attached to the finger, and that is also usually has a pulse where you can actually hear, if you dial it up, you can actually hear that beeping sound that actually tells you sometimes that the oxygen level is getting too low, and alarms as well when there's a precipitous drop or there's significant drop based on where the alarms are actually set. When there's a drop in the oxygen saturation. And on our patients who are on mechanical ventilator, who are on a breathing machine, we also have a capnometer, which is a device that's attached to the end of the breathing tube that measures the amount of carbon dioxide that is exhaled at the end of each breath. And that is also very, very helpful because it really tells us when a problem occurs and allows us to avert a problem before the oxygen levels get affected, meaning before the pulse oximeter goes down, meaning if a patient stops breathing for some reason. Now, on a ventilator, you're usually assured that they're getting a breath if you're on a mode of a breathing where the ventilator is supposed to give you a certain number of breaths. But at times, the tube can get obstructed, and the first thing we always usually see is that capnometer, that end-tidal CO2 monitor, shows that the carbon dioxide levels are changing and going up, and the respiratory pattern is changing.
Thank you, doctor. Now, going then specifically to review in this case involving decedent Michael Jackson, you found multiple extreme deviations in the standard of care. Is that accurate?
That's correct.
And in your report, you went through noting multiple extreme deviations and then followed that with a specific analysis regarding the care given as it relates to insomnia. Is that right?
That's correct.
I want to begin with the deviations you found prior to getting into insomnia. First, you noted that the setting where Dr. Murray was providing the propofol was unacceptable and was an egregious violation of the standard of care. Is that accurate?
That's correct.
Please
What I was referring to was using this drug in a setting outside of a highly monitored set unit or a highly monitored facility, meaning intensive care or an operating room or a surgical center with very strict monitoring capabilities. Really, to someone in my field, to really even conceive of using this drug, a deep sedative, in any place outside those that I mentioned is really inconceivable.
Inconceivable?
Right.
You also discussed the need for the doctor to be highly skilled in airway management and advanced cardiac life support. And in this particular case, found that Murray's treatment was, again, an extreme violation of the standard of care?
That's correct.
Could you explain that, please?
Yeah, I think we went over some of this earlier, but it's really important when you are using an agent such as a deep sedative like propofol that has potential of causing deep sedation and further continuum to general anesthesia, to be able to deal with the physiological consequences that can occur. And what are those? Well, we've talked about the lowering of blood pressure that can occur with the use of this drug, often can be compounded by other medications or problems that patients may have. The stoppage of breathing, which is called hypoventilation, which is a diminishment in the rate of breathing, and then finally apnea, which is a cessation of breathing, can occur due to this drug. So one has